You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for February 18th, 2022. This week, novel methods to prevent post-cardiac surgery AFib, statin intolerance, heart failure with preserved ejection fraction, and vitamin D. The first topic is postoperative AFib, or post-cardiac surgery AFib. And I've opined previously that the only way to prevent post-cardiac surgery AFib is not to have cardiac surgery. That's because for my entire career, I've never seen anything work to reduce post-cardiac surgery AFib. But maybe, just maybe, new research into a different avenue infuses a tiny bit of hope. The new avenue of therapeutics is via the autonomic nervous system. Jack has published a research letter on use of spinal cord stimulation to prevent post-cardiac surgery AFib. The paper was originally presented at the ACC meeting in 2021. But let's do a very brief bit of background first. Jack has published a nice review paper in the same issue. Now, this is modified from that paper. Autonomic control of the heart is mediated via the neurocardiac axis, and it includes reflexes at 3 levels of the neural hierarchy. The first is the central level, the 4 brain structures, the brainstem, and the spinal cord. The second level is in the chest, not in the heart, the stellate and dorsal root ganglion. And the third level is intrinsic cardiac neural system itself. This is inputs from baroreceptors and chemoreceptors. And the intrinsic neural system contributes to beat-to-beat control of the heart. Now, sympathetic output to the heart is directed through the middle cervical and stellate ganglion to postganglionic sympathetic axons to intrinsic cardiac GPs, and then the atrial and ventricular myocardium. In parallel, the parasympathetic innervation is primarily mediated by branches of the vagus nerve that synapse on ganglionic parasympathetic neurons located in the GPs or ganglionic plexus. Therefore, the GPs, which are mainly embedded in epicardial fat pads on the posterior surface of the atrium, are composed of both sympathetic and parasympathetic neurons, and they function sort of as integration centers for the whole cardiac autonomic input and output. Now, when I was at Indiana in the 1990s, Dr. Zipes was intensely interested in this area, the autonomic neural control, but for whatever reasons, it hasn't yielded major breakthroughs until maybe now, possibly. For instance, we originally thought that catheter-based ablation of these GPs in the atrium would be helpful for AFib, but that hasn't panned out. Okay, now back to this intriguing research letter in Jack on spinal cord stimulation to prevent AFib after heart surgery. This was a very small RCT done in 2 centers in Russia. The intervention was the spinal cord stimulation. This was a standard silicone insulated wire that is kind of routinely used in spinal cord stimulation. It was placed by an experienced neurosurgeon. It was placed under local anesthetic and fluoroscopic guidance using a TUI needle. It was positioned in the posterior epidural space at the C7 to T4 level, just left of the midline. Now, this position was associated with the most extensive feasible coverage of the left and middle anterior thorax. The external segment of the lead was then connected to a handheld stimulator, and patients themselves used the handheld controller to adjust the stimulation for comfortable but consistent paresthesias. It was then further programmed by the physician. The spinal cord stimulation was started 3 days before the bypass surgery. It was deactivated during the surgery, and then it was restarted after the surgery. The control arm of the RCT just got standard beta blocker, standard care. The main results were astounding. At the end of 30 days, post-cardiac surgery AFib occurred in 8 of 26 patients in the control group. That's 31%, versus one of the 26 patients in the spinal cord stimulation group. And that ended up being a hazard ratio of 0.11. That's a 89% reduction. Now, my comments. This study does infuse us with some hope. It now seems reasonable to try this in a bigger trial. But a nice teaching point here is on the statistics. The point estimate of the relative risk was monstrously big. The hazard ratio 0.11, so an 89% relative risk reduction. But the problem with small studies is the confidence interval went from 0.01, a 99% reduction, to 0.90, a 10% reduction. That's a huge spread, and it suggests to me that you need more patients. So I guess the most accurate assessment is, I just don't know if this works. Journalist Patrice Wendling has not news coverage, and the most notable part of her coverage is that there are at least 8 randomized controlled trials in progress looking at the role of autonomic neuromodulation and AFib prevention after heart surgery. Now, these include low-level vagus stimulation from the ear, epicardial botulinum toxin, ganglionic plexi ablation, and stellate ganglion blockade. I think these are hopeful early signals, but you have to be extremely pessimistic in terms of your priors when it comes to AFib after heart surgery, because literally nothing has worked in the decades before. Second topic is statin intolerance. Now, we've all encountered this. Patients who cannot take statin drugs due to side effects of one sort or another. The European Heart Journal has published a massive meta-analysis, and I mean massive. This was a meta-analysis of 176 studies with more than 4 million patients, and the idea was to characterize statin intolerance. The first author is, I'm sure I'm going to mispronounce the name, Ibete Batisi from Kosovo, and the author list includes many noted experts in the field. But before I go over the results, I want to set out 4 general statements about statin side effects. First, we know that the rate of statin side effects is substantially higher in unblinded studies than it is in blinded trials. And second, in RCTs that are blinded, side effects on statins are essentially the same as placebo. Third, an extremely novel Samson trial from the Imperial College London team. I've covered this trial before. They found that the statin tablets do indeed cause side effects, but these side effects are due to the act of taking the tablet, not so much the statin chemical. Fourth, I want to mention an interaction I had with an orthopedic surgeon. I had this interaction many years ago, and it's burned into my brain. Now, this was a senior orthopedic surgeon, and we were discussing statins in the recovery room. And he said, you know, Mandrola, you cardiologists say someone's body aches are due to statins, and then I do an x-ray, and they're literally riddled with arthritis. Okay, now to the meta-analysis. The author's ideas were that statin intolerance is widely debated because of these 4 general statements above. Now, I'm middle-aged and already have mysterious aches, so older people are going to have oodles of reasons for feeling achy and unwell. So their idea was to combine nearly every observational study and randomized controlled trial published that reported statin intolerance symptoms, and these range from 1990s to the present, 3 decades. And their top-line result was that the worldwide prevalence of statin intolerance was about 9%. Older age, female gender, Asian and African American races, obesity, type 2 diabetes, alcohol, hypothyroidism, liver and renal diseases were all associated with a higher risk of statin intolerance, as was increased statin doses and the concomitant administration of antiarrhythmic agents. They also found that the prevalence of statin intolerance in cohort studies, observational studies, was significantly higher than that reported in RCTs, but of course we already knew that. One interesting secondary analysis they did compared statin intolerance prevalence in studies of primary versus secondary prevention, and they did not find a significant difference. Now, in a press release, the authors wrote that statin intolerance is, quote, overestimated and overdiagnosed in most cases. They also wrote that this data also means that around 93% of patients on statin therapy can be treated effectively with very good tolerability and without any safety issues. Now, I agree with the author's conclusions, but I don't know that this data can tell them that. I mean, if you go to the main figure, the forest plots of the trials, the results of the individual trials are all over the map. Some find no statin intolerance, some find tons of statin intolerance. Now, we have this measure of heterogeneity called the I-squared measurement, and it ranges from 0 to 100%. And when you combine studies in a meta-analysis, you like this to be low. The I-squared is a complicated measure. It's not exactly a measure of absolute heterogeneity. Rather, it tells us what proportion of the observed variance reflects variance in true effect sizes rather than sampling error. I guess the simple point here is that the I-squared of this meta-analysis was like 98 to 99%. In other words, it's about as high as one can get, and I'm just not sure the combination of different kinds of studies over 30 years tells us much that we didn't already know. My basic approach to statin intolerance is to understand that there is a huge nocebo effect with these drugs, and I try to skillfully explain this to patients. If there is a very strong reason to use the drug, say a high absolute 10-year risk or secondary prevention or young age, I push harder than I would if there was a low absolute risk. And I think finally the statin intolerance question and how to interact with patients makes the podcast because it is intensely interesting to me. It's 10x more interesting than isolating pulmonary veins for AFib ablation. Third topic today is heart failure with preserved ejection fraction. And we're going to talk today about diagnosing this condition, specifically the use of the biomarker BNP. Now, most trials of HFpEF use elevated natriuretic peptide levels as an entry criteria. And in fact, a recent consensus document has proposed a new universal definition of heart failure, which requires elevation of natriuretic peptide levels or objective evidence of pulmonary or systemic congestion to meet the diagnostic criteria for having heart failure. Yet, heart failure is a clinical syndrome and a biomarker is merely a blood test. I mean, a number of previous studies have reported that some or perhaps many patients with HFpEF have elevated filling pressures consistent with heart failure, but they have normal natriuretic peptide levels. The European Heart Journal has published a provocative paper from Mayo Clinic researchers who studied patients with HFpEF hemodynamically, but normal BNP levels. Now, their methods were sort of unique to places like Mayo because they looked at patients referred to Rochester for unexplained dyspnea who then had invasive hemodynamic assessment during rest and exercise, and this was over a 12-year period. I say unique because most places don't have such a trove of patients who've had hemodynamic assessments for unexplained dyspnea. HFpEF was defined by signs and symptoms of heart failure with a left ventricular ejection fraction greater than 50% and an elevated wedge pressure both at rest and during exercise. Their cutoff for BNP was 125 nanograms per liter or 375 for AFib. Now, the study had three groups. A control group, or those with unexplained dyspnea that did not have hemodynamic HFpEF, those who had HFpEF with a normal BNP, and those with HFpEF who had a high BNP. They then described the hemodynamics and followed these patients for clinical endpoints. And their major findings were four. And compared with control patients who had non-cardiac dyspnea, patients with HFpEF who had normal BNP had a higher left ventricular mass and worse diastolic function, but right ventricular function was preserved. The second finding was that hemodynamically wise, those with HFpEF and a normal BNP had filling pressures that were intermediate between those with non-cardiac dyspnea, the control group, and those with high BNP, heart failure with preserved ejection fraction. Third finding is, as you would expect, the high BNP HFpEF cohort displayed the most profound cardiac functional and hemodynamic abnormalities. Notably, they had a greater prevalence of RV remodeling and dysfunction and more significant secondary mitral and tricuspid insufficiency. Their fourth finding was that clinical outcomes, such as freedom from mortality or heart failure readmission, occurred on a spectrum. The normal natriuretic peptide HFpEF did better than controls, but they did worse than the high BNP HFpEF. The authors concluded that their findings provide new insights into the pathophysiology and importance of a large population of patients who have HFpEF and normal BNP levels. And of course, this challenges the consensus that one should require high BNP levels to diagnose HFpEF. Now, another possible conclusion the authors suggest in their discussion was that natriuretic peptide elevation is generally more reflective of abnormalities in biventricular and atrial function rather than pointing towards isolated LV pathology. Recall that right heart function is one of the strongest prognosticators in HFpEF. Now, why is this potentially important? Well, there are two post-hoc analyses from trials, one from the irbesartan trial and the other the TOPCAT trial, that have shown that patients with HFpEF and lower natriuretic peptide levels respond more favorably to ARBs and MRAs as compared with patients who have high natriuretic peptides. The observations from Mayo, of course, support the hypothesis that the generally poor results from heart failure with preserved ejection fraction trials that enroll patients who have high BNPs may be related to the fact that they recruit patients with more advanced stages of HFpEF, wherein abnormalities in the right heart, left atrium, and pulmonary vasculature, these things may require more advanced therapies than just a single drug therapy. In other words, in an effort to enrich trials with high-risk patients, those who have high natriuretic peptide levels, the trialists may have actually selected patients too sick to respond to a simple drug regimen. And I guess I would extend this idea to the Andrew Foy notion of multimorbidity. That is, we clinicians have come to believe that higher risk patients stand to gain the most from our therapies. For instance, a relative risk reduction of, say, 10% leads to a higher absolute risk reduction if the baseline risk is higher. But increasingly, I've come to believe that this isn't true. It seems like there's a sweet spot of benefit of most of our therapies. Patients have to have the true clinical syndrome, but not be so encumbered with other comorbidities to benefit. Indeed, I think this is why the heart failure with reduced ejection fraction trials have been so successful. That is, there's one issue. It's impaired LV systolic function, one target. Finally, before I close this topic, let me also not fail to mention the all-important clinical notion that one blood test, a biomarker, is a far cry from a clinical syndrome. BNP levels, troponin, CRP, LDL cholesterol are not diseases. They are biomarkers, and we would be wise to not overweight these surrogate markers in terms of what we do with patients. Final topic today is vitamin D. In recent weeks, I've made mention on this podcast of a number of non-significant trials looking at vitamin D supplements. And with a little nudging from a very smart person, I went and looked deeper into the vitamin D story. The question at hand is why? Why is the hype surrounding vitamin D so impervious to the evidence? And perhaps more importantly, what are the implications for this lack of persuasion? Now, this phenomenon being that every clinic I see patients on vitamin D, journals keep publishing vitamin D papers, researchers keep researching vitamin D, and now with the pandemic, there's an outside attention that vitamin D may hold promise for COVID-19. What came of my exploration was a 1,200-word column. It's up now on the heart.org Medscape Cardiology website. I don't want to give it all away here. I'd love if you read it and left a comment. Tell me what you think. Here are just a few teasers. There are hundreds of observational studies that correlate low vitamin D levels with poor clinical outcomes of all sorts. Second, there are hundreds of RCTs, and they can be reduced to one sentence. Vitamin D supplements do not improve health outcomes. Third, the VITAL trial, the D-Health trial, all the Mendelian randomization studies, the meta-analyses, the systematic reviews of vitamin D are essentially null. Why then would vitamin D continue to be measured, supplemented, and embraced by patients and doctors alike? In the piece, I speculate about the reasons for this, and like I said, I won't give away the conclusion, but suffice to say the implications, the larger message, transcends one supplement, and it speaks to much of what ails the translation of evidence to the bedside, and also the excess expectations that healthcare actually delivers health. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, it really helps if you give us a rating, write us a little review. These sorts of things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.